Hello and welcome to another edition of Heart of Healthcare. My name is Dr. Jan Bonhoeffer, and these podcasts are about helping physicians restore balance in their lives so we can co-create a medical system that benefits everyone. A quick reminder that you can find more information about our nonprofit Heart-Based Medicine and the work we do to support healthcare professionals at heartbasedmedicine.org.
Welcome to the Heart of Healthcare podcast, Series 2, Episode 9, when we're asking, is the medical health system much alike a patient with ADHD?
Today, we are lucky enough to be joined by Dr. John Kruse, psychiatrist for over 25 years, an ADHD specialist, and the author of the fascinating and highly relevant book, Recognizing Adult ADHD, What Donald Trump Can Teach Us About Attention Deficit Disorder. We're excited to learn how John likens the present medical system to a struggling patient with ADHD and what his advice might be for a transformation to a more heart-centered approach. Welcome, John.
I'm glad to be here today.
Very happy to have you back on the show. And I'm also delighted to welcome back my regular fellow podcast panelist all the way from Hawaii, Dr. Dan Dinenberg. Dr. Dinenberg was one of the original physicians at One Medical. And as a clinical instructor at UCSF, he had extensive training in functional medicine, double board certification in family medicine, and integrative holistic medicine. Hello and welcome back, Dan.
Hi, Jan. Hi, John. Pleasure to be here.
At Heart-Based Medicine, we are looking to create a conversation around how the medical profession could transform to embrace a more heart-centered approach. And you have likened the health system to an institutionalized ADHD closed-loop world. So, John, could you unpack this for us a little bit? We'd like to get a little bit deeper into this enlightening perspective and maybe explore the inherent challenges for change your observation presents to movement for change.
So one of the theses of my book is that there are a number of factors in our modern societies, including social media, but also including changes in how we eat, how we sleep, how we're spending our time, that are making us more ADD-like, and that these very behaviors themselves are behaviors that are excessively engaged in and with people who have ADHD. So there may be a feedback loop going on that our environment has influenced us to be more ADHD, but as we become more distracted ourselves, our communications with others are choppier, less in-depth, less context, less information, more emphasis on responding to what's immediate and what's emotional rather than thinking in depth. So that we are, even people who don't clinically have ADHD are being forced to behave in more ADD-like directions. And that includes the field of medicine.
So expand on that a little bit. So I understand the feedback loop, and that's something I think many of us can relate to, is that we are, the more people behave in a certain way in a population, the more we can actually influence each other, and there may be a spiraling effect. And so that makes total sense and may explain some of the, if you like, epidemiological surge of ADHD diagnosis being made, at least. So how does this affect the system? So what do you see in the medical system in particular reflecting this behavior?
One is the volume and flow at which we're expected to work. So in the generation when I was training, even though there were some time constraints and some expectations, you had to see X number of people and maybe a more inhumane burden into how many hours you were expected to work, there was still adequate time given to connect with the patient, to talk with the patient, to learn and know the patient and observe them over time to gather the information you needed. And at least in the US, and often it's the insurance industry that's blamed, most of the psychiatrists who are being trained today are being trained as psychopharmacologists because they can then see 4 or 5 patients an hour rather than 1 patient an hour. And that theoretically is a cost savings to the insurer because more of them are seeing this high-paid professional over time. But if in fact, they're seeing someone at a more superficial level and less accurately diagnosing or treating problems, then I would question whether there's even efficiencies in the system from doing that. But separate from the efficiencies in economics, clearly the expectation is that you're not going to have time to read the whole chart or look at all your notes from the last session, or because you're only given not just a finite amount of time, a brief finite amount of time.
Yeah. Okay. So the time pressure by the system, let's say by whatever the insurance system is, or whatever the claims, wherever the claims go, depending on whatever national health system we're living in, or whatever health system exists or health systems exist. So there's certainly pressure, financial pressure. And that shortens our time with our patients, and that increases a more shallow response. But in addition to a more shallow response, if I hear you correctly, you're saying it actually leads us to skip over important elements. And if I hear you correctly, it's kind of focusing on the signs and symptoms and possible molecules that resolve or alter the signs and symptoms, while asking the question of who is having these signs and symptoms is being glossed over, or this is what we're skipping. Why do we skip that most important piece?
Probably because it's the hardest one, but I'm going to also jump back a little bit because I brought up the time factor and you continued with that, but your words also emphasize that it's not just less time, but even within that time, we're bombarded with more flows of information or more demands. So our attention itself is more distracted. So I don't know how many patients I've had who've said they've come from the doctor's office, and one, I only had 10 minutes. So almost always the time complaint's there first. But then the second thing they almost always say, and they were talking to their computer the whole time, or they were monitoring other data, or they were checking results from. So we have, the computers brought us a wealth of information, but that's also a wealth of distractions, particularly if you're trying simultaneously to attend to what the old lab results are, what you're observing here, what boxes you have to check to make the people in the billing office happy before the end of the session. So divided attention in a short period of time is a recipe for not getting comprehensive communication with your patient when you're there in the room with them.
Wow. So when we look at when we move back to the ADHD patient or ADD patient, then one of the issues, or one of the points of suffering, is that there is a lot of influx of information, and one of the challenges is to prioritize and separate and categorize this information, and to navigate through this overload of information. Is this a similar phenomenon to what you see as a pattern in healthcare professionals in terms of the way healthcare professionals change?
Yeah, I mean, I think if you're faced with multiple demands in a short period of time, and you have to respond to what seems to be the biggest fire, or biggest crisis, or loudest complaint, it may steer you right towards underlying health issues you need to pay attention to. It may be pulling you in a direction that's largely irrelevant to what may be more pervasively it's going on with that person's health.
And when we hear healthcare professionals, so many of our colleagues expressing their concern, or I would say suffering, from the fact that they're becoming functional units in a larger system, and the initial call and why they became a physician or a nurse or a therapist has been buried or suffocated in all the other kind of requirements. How does this compare to how a patient with ADHD feels?
I mean, I think that the central feeling for many of them who are not happy with their status in life is feeling misunderstood, not that the people are judging them based on what failure to conform to societal norms. But the underlying emphasis there is that they're not being seen or heard as individuals. And as you mentioned, yes, doctors now and doctors ages ago were, doctors work hard. Not all of them, but most of them work pretty hard. But they're trained, most of us know that going in. We're trained to work hard, to work long. And if hard work were just the only factor driving rates of burnout, I would argue we would see more of that decades ago. But part of what's being cut out or what's missing now is the human connection, is being able to help people rather than check off 32 boxes today that I opened, made these diagnoses and fulfilled these billing requirements and did other things. So burnout's not just a result of hard work, it's a result of hard work with diminished rewards, and particularly diminishment of the human reward, which is based on human contact and knowing people as people. So
I can totally see this. So Dan,
Yeah, no, it just resonates. I know the way that you explain that with kind of like the shallow response and the diminished rewards. I think our profession has been one where we have worked extremely hard, but there's such a reward because you're in service to humanity. And that in itself is a loop, a system where then you want to be more of service because it actually feeds you in some way. It nourishes you for coming into the field. And I do hear what you're saying. I think that this, what I see with patients, and I kind of show up in a different way as a physician guide, and I'm there and they're seen and heard and witnessed through their struggles, all of a sudden, what I notice is the internal landscape reflects over time the external landscape. And so if they're feeling scattered and not focused, without empathy, without self-compassion, over time, that's what the outside of their lives start to look like. And then we kind of delve into that. Now I have a practice where we have the ability to kind of drive into both of that, into the physical, the mental, the emotional, the spiritual, which is wonderful. What Jan and I are really excited about talking to you is really kind of the application into the current model of healthcare. So it's like if what you're doing is painting this picture of, let's say, psychopharm and more shallow response and not getting into the deeper reason for what's going on, then how do we bring more heart into healthcare at a systemic level? I feel like I have a really good understanding of how to do it with one patient at a time. But this is something that, like, what you're doing is discussing the system as a part of this kind of ADD setup. How do you see a way to kind of bring more heart from a systemic level into healthcare?
I guess at a systemic level, I think we need to change systemically how much time, getting back to the time, how much time doctors get to spend with patients. And again, I think the only way we're going to be able to do that is sort of a results-oriented and economics-oriented way. So we have to be able to show at some level this leads to better outcomes or better care. And I just saw a review article recently looking at first early studies on depression, where when they finally systematically were trying to look at, this is studies from the late 60s, early medication for depression versus talking therapy, and both had some impact. But when they broke down the data years later, what they found was that the size of the medication versus placebo differential was actually smaller than the differential between the individual psychiatrists in the study so some psychiatrists did really well with a lot of patients, some did really poorly. Mm-hmm. And there's been a wealth of other studies since then across not just depression, but at least across psychiatric medicine, things like schizophrenia, others where we know, there are biological phenomena at place. The medications really do have an impact, but the magnitude of the effect, the placebo medication effect, is actually smaller than the magnitude of the inter-individual doctor-patient relationship effect. That, to me, is saying that that we need to be able to, when people feel connected, when people feel heard, that has an impact on whether they can actually even respond to some of these medications. And I don't think that's at all specific to psychiatry. I mean, one angle of it is just compliance. If you trust your doctor, if you believe your doctor, if you understand why you're taking the medicine, whether it's for your ulcer or your high blood pressure, you're much more likely to be compliant if you, again, feel connected and taken care of than if you feel someone's just throwing pills at you and they don't care. Why should I care? Is enough.
That's so true. I'm intrigued by the effect this has on the individual. I think we may learn kind of possibly for future steps, we may learn from that. And I want to pick up two of your blog titles because I think they're really relevant. While they were intended to talk about the patient with ADHD, if we now move it to this metaphor of ADHD for our medical system, which as the more we talk about it just makes more and more sense to me. It's kind of actually quite revealing. In one of your articles, you call one of your articles "Shrinking the Shame of ADHD." And so this is to do with the patient with ADHD being doesn't fit, right? It's a misfit situation, right? And then it's about, you're lazy, you're stupid, you're not doing the things you should be doing, you're not behaving right. Basically, you are not okay the way you are. That's the constant message these kids receive. And we've recognized for the individual treatment how incredibly important it is for the environment to not go down that route and to actually go into motivation and support. And that's what is actually more than feeling good. It's actually fundamentally healing. So similarly, when I look into where I feel not good enough as a physician, then there are two areas, and we only talk about one. We only talk about, oh, you didn't read the latest paper on Schnick Schnack, and you therefore, bad boy, you didn't do your homework, right? So it's knowledge. It's being insufficient with knowledge. So I'm not good enough because I didn't have the knowledge in the situation, or I didn't apply the knowledge as I could have. But there's another piece, which is that the more we objectify ourselves and our patients, the more we feel not good enough and inadequate, as with that part in us that actually wanted to become a physician or a nurse in the first place. So if we actually want to meet other people, if we actually want to be with other people, if we want to be present with other people, that's why we chose this profession. And we're constantly being told that that's not what we wanted. It's the chronic experience of being a misfit. And that just became clear to me just now as we were talking about. So is this something you observe among our colleagues? Is this just me, or is there something about our colleagues where this idea of I'm a misfit because of what I want, but I'm taught differently?
Yeah, I'm drawing connections to sort of the phenomenon of burnout that we're seeing, particularly in COVID, and another phrase I use a lot, that we should be focused on the quest rather than the test. So the knowledge-based rating, you know all this information, therefore you're a good doctor, is focusing on sort of the immediate contained information at the moment. And ideally that would be aligned with our greater quest of healing people. But I would say fundamentally, if we're in there for healing, helping people take care of their own health, that's our quest, that's our goal. And often the system as it is now pulls us in different directions to focus on the test rather than the quest, and to get into almost any feeling of shame, feeling of failure means that you set up the equation in your own mind that this is a test. Because if it's not a test, if it's just a quest, if it's a goal you're striving for, you can't fail at that at almost anything. You may be frustrated, you may be blocked, but there are ways to get around. If you viewed it as a test, then it's there and over, and you have a bad mark or a good mark on your career.
Well, that makes a lot of sense. I can see a lot of colleagues actually feeling that way. And this is something that I have never seen or heard being talked about. That, actually feeling inappropriate as a healthcare professional by having the fundamental desire to help other people. because the system exactly does not support that. So
Well,
that's
and some of it's being really exacerbated in the COVID era,
right.
where, I mean, it's not just Fauci and people at the top who are being discredited by certain people because they feel there's a political message, but that is then devaluing, all doctors who are trying to use modern medical information to help people with a deadly pandemic. And that also, again, one poisons a doctor-patient relationship for lots of individuals whose politics may make them, not trusting of their own doctor just because their doctor's siding with what the doctor feels to be as established fact. But so there's I would say an increase in alienation and then a decrease in valuing what doctors can do.
Wow, thank you. That really helps me understand this better. Let me try one more, Dan. I know you're burning for another one, but I want to ask about the second podcast, the second blog that is also very could also be educational. Let me ask you that. So the other title was Narcissism or ADHD. And we talk about particularly doctors being narcissistic, right? Being very full of themselves and authoritarian and patronizing the patient and manipulative and kind of having the idea of I know best, you have the problem, I have the solution. So where does that come in then?
So the original article was discussing, if I'm getting too far into politics, you'll pull me out of it, but with a certain past president, there was so much, almost every discussion talked about how he was impulsive, how he couldn't sit still, how he was disorganized, how he was distracted during talking. And then they'd say, and he's a raging narcissist. And they were describing a host of ADD behaviors, and ADHD is the one major psychiatric diagnosis that right now is diagnosable based entirely on observable behaviors. So if someone interrupts you, someone enough, can't sit still, fidgets, does at least 5 out of 18 different symptoms on a regular sustained basis in ways that cause trouble, by our official definition, you can say they have ADHD. Again, it's behaviorally driven. You don't have to know what's inside their head. With narcissism, you have to know that they're thinking and feeling and have some disregard for the value of other humans. And the difficulty is that lots of behavior can look similarly. So lots of people with ADHD come across as very self-centered. They're talking about themselves and they forget to ask about others. They're literally and figuratively stepping on other people's toes. Does that mean they really disregard or don't care about the other piece or devalue them? Or does it mean they just weren't looking or caring or not caring or paying attention?
It's so interesting because there are, because of this widely spread observation or sense that physicians are narcissistic, while when you ask the physician whether they are narcissistic, of course they would say no, and you would say like, well, there you go, here's the narcissist, right? But actually, if that was correct, that it is not about narcissism, but it is about a trained behavior of attention deficit, then that would truly change a lot of the relation between patient and healthcare professional, including the self-relating of healthcare professionals.
Yeah, I hadn't applied that concept to the medical profession, and I think it'll be interesting to think about it more deeply, because there's certainly a lot. I mean, even sort of when patients in my office are complaining about their medical doctors, a really common one is, if they are 2 or 3 minutes late, they're cut off or told you have to wait in the waiting room, but the doctor is routinely, 10, 15, half hour late, depending on what type of specialty and how the flow has gone. And I would say invariably, and maybe I'm dealing with a less psychologically healthy population than the general world, but invariably it's taken as signs of narcissism, that these arbitrary rules are applying to me and not applying to themselves, rather than so that would be the narcissistic model, when if we view it maybe more as a factor of the ADDogenic, scattered attention, multiple demands, more than anyone can accomplish model, that I think would allow patients to be a little more, I mean, sure, nobody's going to enjoy waiting an extra hour in the waiting room, but having more comprehension. The doctor's not doing it because they're devaluing me. They're doing it because they're that busy. I mean, I'm sort of, except for today when I was horribly wrong and had the time off, I guess I'm noticeably punctual, and I routinely apologize. I have lots of ADD patients, so I do get pulled. Instead of having 5-minute break, as common in psychiatry, I often have that boundary disrespected. But if I'm 1, 2, 3 minutes late, and that's the latest I usually ever am, I'll apologize. And the patients uniformly are, why are you apologizing? You know, coming from a doctor, what's going on here? And what's 2 or 3 minutes? But I think that sort of my approach there helps to break down any conception that I'm keeping them waiting because I'm disinterested in them, or because my needs are greater than their needs.
I mean, it's really interesting when you start to look at that. I've noticed even in my own evolution in my practice, it's like I used to sit, you know, in my office, you know, maybe I thought 3 or 4 inches higher, kind of looking down on my clients, patients, and just the way that the whole thing was set up is it put me in a situation where whether I had narcissistic tendencies or not, the patient experience of it was set up where, you know, they were lucky to have my time and they come in and then they go out, and that's kind of what it is. And so, you know, I've been in an evolution of recreating that in every way, so it feels co-creative and it feels like an exchange. And I think that, you know, what you're saying by apologizing or for letting that, you're showing them respect right away. You're showing them that. So I think that that's incredible, and I think that that is a possibility for future scenarios. And how do we rework the system? Another thing that's been brought up that I think is really interesting that kind of struck me is there's a word, the effectiveness that we spoke of. And I think that is an opportunity to really revolutionize healthcare, because at some level, whether the narcissistic physician or anybody else, I think what we're dealing with is, look, if the shallow response and sort of, you know, the analogy I thought of is like, as you're explaining patients, is almost like, you know, the bathtub and the drain is still going down and there's nothing that you can do. It's almost like the emergency room setting where, you know, are you really being effective? Are you giving someone 12 pills to get them out of the emergency room, and they'll probably come back in a couple of days, but you don't have to deal with them then. So you're just putting off, and we're not actually getting deeper into the reason for what brought people in. And so in my own life, I see that. I see effectiveness and creativity are the 2 factors that actually build my own resilience, where I don't even, you know, the burnout is not an issue because of those things, because I'm creatively designing the way to interact with a patient, and then it actually is effective. So instead of, you know, kind of talking to your idea of SSRIs and the patient connection, I believe in what I'm doing. I'm deeply connected to the patient. I deeply believe in the treatment, and I stay with it, and there's continuity there. I think that is, you know, that is a possibility. I think what we're kind of driving to, though, is just in summary, if we have to talk faster and listen quicker and get to a place where, you know, everything is sort of what I would consider almost this push button reactionary, like, oh, they come in, they say this, I listen quickly, and then I give them this in the sort of psycho-pharm model. How do we evolve? What is that? I mean, I think that this is an incredible conversation, but like what I'm really going for is like, you know, we all can do the internal work and we can evolve as our own practitioners. But what we're trying to do is model that and send that heart into a system. And I think that's the opportunity. How do you see that moving forward?
So I was glad you're bringing it back, because I was about to come back to your earlier question systematically. I think beyond just the time dimension, that removing distractions, and to me, the way that this will evolve, and there are legal and personal privacy issues, is that probably there will be some recording system that's taking all the data. There'll be natural language process systems that scan it for all the things that the chart needs for billing, that can fill out so that when the doctor's interacting, they are interacting, much as they were 50 years ago before all these distractions arose. And I get that these distractions have been added in an attempt to make us more quantitative, make us more objective, make us more valid in what we're doing. But I don't think that all needs to be as intrusively taking time and attention space during the sessions as they are now. And unquestionably, they are now. I mean, I can touch type, so I can, listen and talk at the same time, but lots of doctors can't. And even if you can, if you have to click on buttons, that's pure distraction. Even if it's
how do you see that perfect scenario then? I mean, do we learn touch typing, or are you talking about an AI machine learning?
I'm jumping ahead of where we are but I'm sure Google and Apple have their own. I mean, they're scanning what's going in. They can extract, who has a blood pressure problem. There's natural language programs that can, run through the checklist of schizophrenic or depressive symptoms more thoroughly than we can, and be monitoring physical variables of the patient's reaction in the session and incorporating blood pressure and all the other data. So, I mean, I guess one worry is, will that cut doctors out of the picture entirely? Maybe, further beyond will be Spock's transformer, or whatever they called their Star Trek, little device that does the diagnosis and the treatment and just wave it around. But I think that at least for some years or decades, there will be a space where all this flow of information, the doctor's comprehending at their level. But again, the doctor, do I really have to check? Do I not only have to ask whether the patient's suicidal, but do I have to check a box, ascertain suicidality, check whether it's desires or just thoughts of it? It's redundant. I mean, if you had a simple recording would save it for, the record's sake, but again, in a way of extracting most of the vital information. And I think, the same, whether it's cardiology or somewhere else, the same information can be extracted that's pertinent.
You bring up a very interesting future scenario, and I think that there are places, whether it be, for sure in dermatology and pathology, or not mentioned in psychiatry, there's ways that we know that computer recognition, pattern recognition is going to move forward our field. I think what you're opening up the question to, which is really exciting, but for me, a personal belief would be that this emotional intelligence, this deeper connection as human technology of being able to develop the subtle clues that is actually part of our human species. And you look at any primate and any cooperative community, and there's so much subtle knowledge that is being spread just by observation, by deep listening, by being present, that this is a place that I don't believe computers or machine learning can overtake. And so then we might have a niche that is bringing us back to that deeper connection for the future. And it's exciting. I mean, it's exciting to kind of continue to grow within that. I don't feel personally like any concern that I won't have a job or a niche within this, because as we evolve, it's like, this is, how the computers can support what we do. Jan, when you think about this with kind of future perfect scenario and kind of John's work, and then kind of like, how do we, with the basis of kind of an ADD, which definitely feels like it, like, scattered, unfocused, non-empathetic world that we're kind of all a part of, how kind of bring this together for us? I love the way you think. Can you bring this, like, how do you bring this into a kind of future healthcare scenario? And what questions would you want to ask someone like John?
Yeah, well, thank you. I have tons of questions. And the last half hour has really has been kind of readjusting a lot of how I thought about the future might be possible. if we think about changing the future, it's a good idea to start with the diagnosis and recognizing the presence. And so what I've learned today is that there might actually be a systematic training of healthcare professionals at all levels into an ADD-like behavior. So not into a disease, if you like, but into a certain way of behaving that has the shallowness and the distractedness and the kind of emergency mode, and also the idea of I'm not good enough and feeling like a misfit. And that we have, in a way, ignored an important part of the healthcare professional's very cause of becoming a healthcare professional. And that actually leads to a chronic feeling of being a misfit. And so we have to compensate for that. And maybe a lot of what we see in terms of our current habits as healthcare professionals that we are suffering from ourselves and that our patients are complaining about may actually be understood better and compassionately if we actually explore this more deeply, as John has said, like let's have that conversation and go into this, unpack this even more. I would love to see that the initial calling of why many of us have become healthcare professionals, that we could actually build on this and strengthen this. And I would love to see that as technology and robotics and AI are going to be very strong in our field, that they do things that we do mediocrely well, like memorizing stuff and integrating new information, that they will be doing a better job and they will become amazing assistants. So that means that in the future, we will have a much bigger call and a bigger emphasis in the training, in the education of healthcare professionals on sensing who we are, on being more heart-driven, on being more connected, on being more present with the patients so that we don't have to listen faster and the patients need to talk faster. So that I would really love to see that. And the ADHD analogy is, I thought it was a little bit far-fetched, to be honest, but the more I go into this, I think there's really a lot to learn. So thank you, John, for bringing this up.
You're welcome.
Let's actually really go ahead and unpack this further in other episodes. When people want to know more and learn more about you, where might listeners find you?
So my book is available on Amazon and at independent booksellers. So again, it's Recognizing Adult ADHD. I'm also have written more than 140 articles on medium.com under my name, Dr. John Kruse. I do have drjohnkruse.com website, although I'm not doing much to actively keep that current, but there's a web address there if you want to email me directly. That's contact.
Well, that's wonderful. Thank you. So we will certainly be in contact, and I'm sure that there will be responses and reactions to what we have discussed today. And I hope that you enjoyed this episode of our Heart of Healthcare podcast, Series 2. And for others, for all your listeners, you can find more information at heartbasedmedicine.org. And I deeply appreciate if you could click subscribe on whatever platform you're listening to this podcast on. So until next time, thanks for listening and stay heart-centered.
This has been a Heart-Based Medicine production. Thanks for listening.